Introduced Jody Platt when I introduced Kelly. Jody is associate professor in learning health sciences and really one of the most visible people at Michigan and elsewhere on AI policy and ethics. So she's going to moderate the Q&A session.
We need our speakers to do that, but as we do that, thank you. Come up to the microphones and start asking your questions. I have a couple if people aren't ready yet, but we'll do questions with our last two speakers and then spend the last 5 minutes with some final words from everyone today. So do we have any questions yet? All right, I'm actually gonna start with the same question that your colleagues got this morning about sort of the trustworthiness of AI from the patient perspective. Is that necessary? Do we need that? Is it just, can physicians do the job? Can health systems do the job? And AI is just a part of all of that and doesn't really matter.
I don't know if this, okay, there we go. I think I have basically the same answer, which is that it's dependent on the use. But I don't think that we necessarily need like a patient stakeholder team and some formal consent process for literally everything in the same way that we already don't for a lot of different clinical decision support that's many years old. But for things like recording patient visits, like yes, I think quite clearly that patients should be involved in that process and understand and trust it. So yeah, I think to me, if it's patient facing, that's a clear bucket. And I don't know exactly where the line falls in between those things, but I don't think I'm necessarily on the side that patients need to be considered like the true end users of a system. I think sometimes they're not, and that's okay.
Mm-hmm.
Yeah, we're not actually sitting on the fence. I think it depends is the answer to that. Because I think there are a number of different ways that patients can participate in the design process that could be really meaningful. So I have colleagues who've been working on a remote monitoring device for persons with cardiac heart failure. And they live in remote areas. And so now they're working on the AI version of this. And they are actual patient partners in the work of this. That I think, and even the tech team and the research team and the clinical team are saying, yeah, things are coming up that we hadn't even thought of. So in fact, from a quality perspective, getting in some ways with the remote monitoring, that the patient is the end user in that respect, but they're not the only one. I guess the other thing is though too, is that the trust is earned. And so there may be settings where talking to patients about the way technology is being used is actually trust building. Mm-hmm. And we may need to be mindful of that. And there's some of the, and I mentioned this at dinner last night, some of the trust studies that have been done in different countries and different health systems shows that, at least when I was looking at the Canadian data, Canadians seem to be really trusting of their healthcare institutions and their universities. Mm-hmm. So they might be up here, and life insurance and health insurance companies are down here in terms of the degree to which they enjoy trust. But that's a steep hill to fall down, right? So I think we would want to be mindful about the state of trust before assessing whether or not patients should be engaged or not engaged. And if it's very poor, then perhaps maybe some thoughtful methods of actually building some trust would be really important.
Yeah. Any other questions? So my other question sort of at this, so we've talked a lot today about context. Mm-hmm. Context matters a lot. And yet we're also talking about governance, right? So there's sort of is this sort of, it's not an either or, but how does the sort of local governance question intersect with the global governance question and the national, the sort of different levels of governance, and how do you make it meaningful at each of those?
Mm-hmm. I don't know that I have an answer for that, except to say that I have found myself actually drawn to work at the local governance level, because I think that's where I can see the context and the actual people doing it. And I am often still looking for, I think the thing that you're mentioning, like who are the people, or you were also mentioning, who are the bridge builders that can get us from the principles to what actually happens on the ground? Because I think right now I don't think folks are returning to principles all that often in the work that I see them do on the ground. It's very much focused on like a really practical problem, or a lot of cases in ethics, like a crisis that we're now resolving. And I wish there was a little bit more dialogue between the two.
Yeah, I think the global context is challenging, and I think but I think the actors in the midst of it have changed too. So we've got these big or giant tech companies that are moving into the AI context, and you can see where having the equivalent of the G7 principles or rules that are locally implemented and interpreted and engaged with, but at least are something that are at least a baseline of expectations that are shared, means that it sort of rebalances where power actually is. The European Union, for example, is, they're still independent countries, but there's strength in having a common approach. So that's one observation I would make. But even within our states or our provinces, I think we still have what is institutional culture and context. But what we're hearing from our folks is that they would like to see some sort of general approach that we all share, so it's a little more predictable. But nevertheless, it needs to be meaningful locally. So I think we'll need to necessarily traverse those levels. We can't just choose one.
Another question that I often get is so who's the leader? And that could be globally, and sort of that kind of thing. It's like, who should we be looking to right now? It's a hard question for me, which is why I'm sharing it with you.
Go for it.
I mean, I guess at the local level of like a healthcare institution, I'm encouraged by positions popping up for chief AI officers, whatever that looks like, as a leader or someone who can see the big picture. But I think actually I'm like fairly uncomfortable with the idea that one person's involved. I think this is going to be teams of people with different levels of expertise. So I recognize it's not like a super clear answer to that, but I guess I think of it less at like, who are the people, but what's the process by which you can defend the decision that you made, regardless of who is making it. But yeah, I don't want to abdicate responsibility for that. So I recognize that's not a super helpful answer.
It's an interesting answer.
Well, I think that every party to the design through to actual deployment and integration of AI has a leadership scope. But one of the things I've often reflected on, and I wonder what you think, Kelly, is that I wonder if part of the ethics conversation about this particular suite of technologies has gained as much traction as it has, at least in part because it was the computer scientists who flagged it as, we are worried about the potential of this technology to do things, and we would like to set some standards for our own practice. And then, which is quite different than, say, government started to, or university presidents, or the ethics folks started to say, you computer scientists, right? So I think that there is sort of a storyline here that actually necessarily made this more of a shared learning, not shared learning, it was shared learning, yes, but shared leadership emerged here, which is, it's maybe the last time we may have seen something like that, it was about, say, genetic engineering, sort of germline genetic engineering, or the Silomar principles. Again, it's like was the scientists self-regulating? There's a self-regulating dimension here, which I think actually created space for a different type of leadership to open up the conversations.
Yeah. Right. Question?
At the last Midas Ethics Conference. It was just a few weeks ago. There was one of the pharmaceutical companies who had their AI leader there speaking, and it was interesting to note that he put human in the loop at the front of how they were going to operate. And I brought up then that there's a whole philosophy that there is knowledge without a knower, and that I think it is particularly relevant in healthcare that we remember that the deadliest intelligence ever known to this earth is the human being. So if you're going to argue that you're going to put people in charge of this new intelligence and that's going to fix it, I'm sorry, but you're lost me.
Yeah, I mean, on the one hand, I agree with that. On the other hand, I don't want to remove humans or we don't remove humans by just relying on AI because those AI are also made by humans. So I think there's no way out of humans in the equation. But I would agree that I don't think the human in the loop as at least the primary method of solving accountability is enough. I think there are other things required. And that we are at the one hand attempting to use AI to help rid us of the human bias that we might already have in our practice. Maybe we can make it better with AI. At the same time that we are, I am at least tremendously scared of the things that you mentioned from Ruha Benjamin about the scale of automation of these systems built by humans. Means that our bias can just be amplified rather than minimized. So,
yeah. I mean, and I think it's maybe human in the loop. Is it human or humans in the loop? I mean, there are more people than just a single human or single actor. And I think that actually creates a context for some checks and balances. And let's be clear, too. We're sitting in, a high-income country with, a history, social context, its worldview, ours in Canada is not so dissimilar. Our worldview is shaped by location and history and all of these features. And someone's worldview, we've got colleagues in Pakistan, and they're saying, you know what, your focus, they will observe to us in ethics, you guys are so fixated on autonomy. We're really into the family, so the individualism. And so we don't even know what our worldview is imbued by a set of values. And so I think this is where we do need to have more people in the room, more humans in the loop for these conversations. Now, but what I hear being said here about the pharmaceutical company saying, we put humans first. So is personalized medicine. Yeah, but someone's going to make money off that. So it's really whose interests are really front and center. You can use pretty language and you can say, oh, we're human-centered because we put humans there. It's like doing a study saying we're really interested in women's health because we treat women. But it's missing the whole point. That's not what women's health is, just because you treat women. So you need to get inside look underneath the hood to see what the actual interests are. I mean, it's like greenwashing, like AI, that we're going to AI that. Well, that's not going to sell a product, but it will sell a product because it's very effective.
Yeah. How do you think about the question of education? What do people need to know about AI to either just to make a judgment about it?
Oh God! I don't think we even have a good definition of AI, to be honest. There are so many competing definitions about it. I do have colleagues too who say, let's stop talking about AI and let's just talk about machine learning. Let's get away from using the word intelligence. I don't know. Can I just say it?
You can say you don't know.
I don't
That's
know.
fair. I don't know either. Oh, well, go ahead. You can go ahead, Kelly. Do you know? Or have
No,
an
I don't
idea?
know. But I guess I would say that I think, as I sort of alluded to at the end of my talk, I don't think for many of these applications you have to be super well versed in the technicalities to understand the ethics. And I say that as someone who doesn't understand all the technicalities, so that is a viewpoint that I recognize and a bias that I recognize. But I think a lot of these things about data privacy, about consent, these are things that like people, because they are people, can have opinions and values about that should be understood and valued, even if they don't necessarily understand everything that's going on under the hood. So I think in terms of education, the cop-out answer again is that it's context dependent. Like clinicians using a particular model might need to know way more about it for some things than they do for others, depending on how it works. I mean, I think, if AI really works as well as we want it to, clinicians shouldn't have to know that much about what's under the hood. It should just work. Mm-hmm. And that's, in some ways, the very essence of its value. To me, I think the big role is finding more of these mediators that a bunch of folks have pointed to, who do probably need real expertise in a bunch of domains. So they will be unicorns, but when we can find them, I think that's a lot of the translation work. But I guess my bigger point is that I don't think we necessarily need everyone to be an AI expert to be able to say something about it. Mm-hmm.
One of the things that you said, one of the people that provided comment on the study, it was about, the physician says, I'm going to be using this to better enable me to take notes, and I want to focus on you. And then but the reaction to that was, oh, this is somebody who's going to be listening in, what's going to go on with my data. And so in some ways, I wonder if there are, AI means something, it means something like to understand the way that person was reacting is, this is fearful, this is scary, this is going to do me harm, even though they were missing the point that this was actually just a way to actually capture only what's being discussed there. So it's in the same way that sometimes the conversations around vaccines assumed something about what that person's perception was, instead of actually understanding that, oh, this was about trust. It has nothing to do with this is code for, I don't want this AI, is really code for, I don't trust you.
Any other questions? I have one more, I think, about this notion of, okay, well, it doesn't really make, so if safety and efficacy is the thing, right, that's most important to people, and that's something we hear a lot, that people want to know, and one of the things they want to know is around safety and efficacy. Is that something that we can, at this point, or do you see a future in which we can sort of communicate safety and effectiveness? And if so, how do we do that, especially in the US or in Canada or both? But is that going to fall to local institutions because we don't have capacity at national levels, or will we see something new emerge?
I guess my immediate inclination is that it's going to first fall locally to the most well-resourced institutions that can run the RCTs. My hope is that from what we learn from those institutions, we can figure out whether there are ways to be more generalizable, though again, I think it's really tough when we're talking about a lot of different contexts and a lot of different people. So I guess I would just say, it has to come. I don't know that it comes from FDA, because I think we've seen that hasn't worked comprehensively. So I guess my hope is just that we will innovate at the level of the local institution first.
So I think I'm sort of mulling what your question was. So is it, were you asking about how we communicate about safety and efficacy of whatever the app would be, or can you just say it again?
That's okay if it wasn't entirely clear. But I think, so if we know that safety and efficacy is important, mm-hmm. what's the sort of roadmap to getting there, maybe?
Mm-hmm. Well, I mean, obviously, we're going to have some sort of research opportunities, for sure. But I'm also thinking, too, about, you mentioned FDA, but institutionally, it's the decision maker who is the one who's accountable for bringing it into or enabling or supporting it in an institution. And so I know that speaking to some of our colleagues who are in their own institutions right now, the early and mid-career health leaders are saying, who do we go to who we can trust to have done some of that more technical sort of examination? Is this safe or is this effective? For example, from a vendor, like what are the standards? What can we expect? How do I discharge my duties and responsibilities to ensure that it's safe and effective if I only know this bit about it, right? Mm-hmm. And so I think there's this nervousness right now about that. So I do think literacy, building people's literacy, maybe it's about the unicorn, of the person who's got all the attributes who could do it. But I also think we may need to revisit and refresh some of the systems and structures we have. And certainly we know our drug technology or our health technology assessment bodies are really worrying about this and trying to think about what their role is with respect to devices or processes that learn. So, yeah, maybe I'll just, I think it's a work in progress right now.
Sure, certainly. Sure. I think, who was it said we're at the beginning right now? That is, yeah.
Hi, thanks for your great talk. My question is about some kind of data when we have lack of data, how simulating data would help in terms of no-show patient or anywhere that we don't have enough data, how simulating data can help us, even with perturbed data, when, for example, but intentionally or unintentionally we perturb data, can we cover the gap or everything related on that? Thanks.
I would throw that to you guys.
We can actually have you guys come up because we'll probably have time for you to answer, and then we'll go into our final question of the day.
So what I would say is I think there's absolutely a place for synthetic data, especially if we want to support smaller institutions to really understand whether or not a tool works in their system and how it's working over time, because they don't have enough data to do it on their own. I think the challenge there becomes they also don't have the analysts to do that synthetic data generation. And so having a larger infrastructure to support them, to help them create the data they need to understand what's going on.
So I'm going to agree with that, and I'm going to say part of this is that structure of the AI assurance labs that we're talking about, which is, can I create enough of a prior probability to say, I think this tool will work in your instance, and I will couple that with the data you do have to reach a better estimate. So I think that there's definitely potential there. But I'm going to stick to my message and say, you don't know about the population until you actually implement the model and monitor its performance and impact. So.
All right, so we're coming to the end of the day, and I want to make sure before we all go, we have one more question for our speakers. They're going to get the last word, but I want to thank our collaborating program, eHail, and the sponsors of today, which are Midas and the Learning Health System Collaboratory, and to thank you all for being here. Thank you so much for your engagement and questions. And our last question for each of you is just to comment briefly on the most important thing that you heard today. And yes, we'll be writing it down.
I can start with maybe a cop-out, but a lot of us have said this, that I think you don't know whether a tool works until you test it on the messiness of a real-world situation. That, to me, I think is maybe one of my big takeaways.
So I guess what I would say is something I would like to think more about and do more in, and maybe it's like sort of a gap that came up a couple of times, is A lot of what we've talked about are examples in resource-rich institutional settings. And I wonder, how do we facilitate the transition to make this more, these resources, these tools available more broadly, so that we actually don't create new haves and have-nots. I mean, so thinking about low resource in multiple different ways. I mean, globally, for example, or within our states or provinces, or with one institution to the next. Particularly, say, in community-based settings, or in public health, or in mental health services in the community, and some of these other orphan areas to begin with. So it's left me with something that I feel like I need to chew on. Thank you.
I'm going to make sure you have the actual last word, so have fun with that. So what I would say is that my takeaway was really that innovation's exciting, but we just have to already move past that. I know things are changing constantly still, but we can't wait for them to just be good. We need to just move past that and really have institutions commit to the really difficult work of implementation science and doing that multidisciplinary design work so that we can actually see if the tools are working, design well-functioning implementations, assess them, not just for the impacts that we're hoping to have, because hopefully we have those, but also for the ways that they are going to shift the care process in other ways that may or may not be good as well. But doing that hard work now rather than waiting for AI to be what we really hope it will be one day.
No pressure at all. So on a lighter note, I appreciate that the subtle unicorn, picture that I put out there has resonated with people. And so I am reassured that I understand, that gap where we in healthcare are trying to find our partners in the data science and ethics and policy space to make things happen. Like, we need to bridge that. And I would say my feeling is an optimism that we're actually talking about the same systems and we're reaching these points of interaction. And I think with the tooling that's coming in and the reframing of our policy and ethics and risk about what a learning healthcare system does with these tools, I think that kind of that energy that we need to overcome to actually make these things happen, that barrier gets lower. And so I'm left with some optimism that we are converging on the same concept. So that way we don't need, we cannot build this based on a handful of unicorns. And I think, now that Karen Deep's not here, I'll say this, this chief AI officer position, I think that's still uncertain how that plays in. It's an important role. But I think that you definitely still need the experts on both sides, and you need to just that convergence that I showed you. We need to spread that, that the color overlap. I mean, that's the goal of this, and that can only happen with people that are at the forefront of it. And so, upskilling, giving them the right tools. I think that's, we're talking about the same things, and that excites me for the future.
Yeah. It is an exciting future. Thank you so much, and hopefully it hasn't started raining. Enjoy some summer. Thank you.